Hello, everyone. Welcome to this IHS webinar. My name is Marcio Nathan Souza. I'm a neurologist in a headache department of the University of São Paulo in Brazil, and a member of the electronic committee and the juniors group at IHS. We all know that migraine is a highly prevalent and disabling disease. So yet many people living with migraine are still undiagnosed and undertreated. That's why the International Headache Society embraces the campaign Migraine Awareness in 2021 and decided to offer this webinar in such an important theme as migraine treatment. Talking about IHS activities such as this webinar, we also want to highlight that the associates have access to videos, podcasts, meeting presentations, everything in the Learning Center at the website. Also access to cephalalgia, publications at the Neuroscientist, early access to international guidelines, and the juniors have benefit from fellowships, educational events, and we all benefit from the possibility of networking through the IHS member directory. Having said that, today I'm together with my co-host and colleague, Dr. Henrik Schutz, who is a neurologist at the Danish Headache Center and co-chair of the Educational Committee. We are happy to welcome you all to this webinar. We have two international experts to talk about migraine treatment. I welcome Professor Piero Barbanti, who will talk about migraine treatment, and Professor Anne MacGregor, who will talk about migraine treatment in pregnancy and breastfeeding. I encourage you all to send your questions with the tool we have here, the Q&A session. And also write down, please, your name and where you are writing from. So we'll start now with Professor Piero Barbanti. He is an associate professor of neurology and director of the headache and pain unit at San Raffaele University in Rome. He's the president of the Italian Neurological Association for Headache Research, and he started working in headache since 1988. His clinical and research activities are primarily focused on headache pharmacological treatment. He has led, as principal investigator, 51 phase 2b, 3, and 4 clinical trials in headache and pain, and is the coordinator of the Italian Migraine Registry. Professor Barbanti, I welcome you and looking forward to your presentation.
Thank you, Marcio. Thank you very much. Now I share the screen. Does it work?
Yes, perfectly.
Thank you very much and welcome you all. I have today two very difficult tasks. The first is to summarize migraine treatment. The second is to do it within 20 minutes. Here are my disclosures. When we speak of acute migraine treatment, we speak of the attempt to act on a dysfunctional trigeminal vascular system, which is a smoking gun of the migraine attack. Have you never asked yourself why you can treat acute migraine with different drug classes? It's easy to answer, because the activation of the trigeminal vascular system implies the release of neuropeptides, so you can act with trigeminal targeted treatments. You have also the biomarker of inflammatory reaction, because there is a sterile inflammation, and this means why anti-inflammatory drugs are active. And you have also vasodilation, and that means why ergots and triptans do act on the attack. More than 1 century passed since serendipity to science, since the first description in the 2 centuries ago on the role of ergots in migraine, acute migraine treatment, and sumatriptan. We now have, or will have, 6 different classes of acute migraine treatments: ergots, anti-inflammatory drugs, paracetamol, triptans. In the US, Japan, and we are waiting for details. So moving from unselective or sometimes unspecific drugs to selective drugs. This journey has also witnessed the transformation of a stepwise care. Please take this. If it does not work, take that. To a stratified care according to the level of disability, and to, let's say, a personalized care based on the patient condition, patient age, and patient comorbidity. I find that this meta-analysis very useful. More than 100 clinical trials with triptans compared to placebo, to anti-inflammatory drugs, and to ergots. This is a pain relief result. You see that the proportion of responders ranges from roughly 40% to 62%. But as you can see, the performance of acetaminophen and ibuprofen is not as bad because it resembles that of triptans. The second point, please look at sumatriptan, zolmitriptan, and rizatriptan. Depending on the different formulation, oral, nasal spray, or the red bar, subcutaneous, you have different responses. Here you see the pain freedom responses with these drugs. And as the red lines tell us, there is a more definite separation between the lower effect of most anti-inflammatory drugs and the usual better effects of the triptans. But once again, please note that the magnitude of the effects also depends on the formulation, not only on the of the type of the drug. We should study some pharmacokinetic parameters of the drugs that we daily use in our patient to acutely treat migraine. If you see the pink box, you see the very good, the excellent bioavailability of most anti-inflammatory drugs. We also have a very good Tmax, which is the speed of action. That explains why these drugs, which has not the same pharmacodynamic effect because are unselected and unspecific, may nevertheless be effective in migraine treatment. So let's have a look to these numbers. And we should also know that some compounds, provatriptan among triptans, and naproxen have very long half-life, which accounts for the reduced risk of recurrence. It would be nice to predict you will respond to this drug for sure. It's not easy to do, but we know now for sure that the sooner the better. Early dosing is necessary because the therapeutic window in migraine is very narrow, within 1 hour. Otherwise, in more than 70-75% of patients, you have a central sensitization, which reduces the effect of the acute treatment. We have long studied the role of some endophenotypes in the possibility of predicting a good or a bad response. And we found and described that those patients who later on will develop allodynia, who have unilateral pain, mainly periocular pain, associated with mild, sometimes cranial autonomic symptoms, do respond probably better, at least to trigeminal targeted treatments. We cannot exclude some genetic background. On the other hand, other researchers pointed out that when the headache, the migraine headache is very severe, the patient having a very a full-blown migraine phenotype with extremely severe nausea, photophobia, or affected by depression, respond less to acute migraine treatments. Now we have also some news. We have GEPANs. GEPANs are small molecules who do not cross the blood-brain barrier and who act as antagonists at the CGRP receptor. CGRP is a short peptide which is implicated in vasodilation and the increased speed of nociception. 2 molecules are already approved by the FDA, are ubrogepant and rimegepant. I want to stress the fact that the primary endpoints are very strong. 2 hour pain-free, no longer pain relief, which is very difficult to assess, and 2 hour mast basal symptom-free, because after all, migraine is headache plus motion sickness symptoms. And as you know, both compounds are more effective than placebo, and their tolerability is comparable to placebo. Nausea, which is the most frequent symptom, is really as frequent as placebo. But we also we'll have in the next future triptans, which are exquisite neural acting drugs which act as agonists as 5-HT1F receptor. Lasmiditan is the first in class, and I want to show you the fact that the study, the Samurai, the Spartan study, have been performed in a complex migraine population made of patients having, in most cases, more than 77% of the cases, cardiovascular risk factor, which preclude the safe use of triptan, for example. As you see here, once again, 2 hour pain-free and 2 hour most bothersome symptom-free as primary endpoints, and the response was significantly better than placebo. However, the tolerability is quite different from placebo, and dizziness seems to be a sort of class-related adverse event, probably due to the fact that this drug crosses the blood-brain barrier. So let's have a synoptic view to the compounds I did not consider ergot, which are no longer used, at least in Italy, are no longer marketed. And as you see, triptans, the range of responders is extremely wide. But if we consider the absolute values, still triptans perform better than the other, even when considering pain freedom or the therapeutic gain over placebo. However, we know that triptans are not safe in patients with cardiovascular comorbidity as anti-inflammatory drugs, apart from aspirin, which is protective. On the other hand, gepant and lasmiditan are safe. Gepant seems to be the only one who have no class-related adverse event. Please do not forget the standard of care. Why? Dr. MacGregor will focus on that later. For example, a woman with menstrual migraine and dysmenorrhea may have advantages more from an anti-inflammatory drug. Rapidly developing attacks may be treated with subcutaneous formulation of triptans, patients with comorbidities with gepants and lasmiditan. And one very interesting aspect is that gepant has been studied in patients up to 70 years and also in some studies with lasmiditan. Now let's move to the second part, preventive treatment. Migraine is not a disease of peripheral nervous system. The origin of migraine is in the brain, and there is a dysfunctional neurolimbic pain network. Please always remember that pain and emotion are strictly interconnected. Why I'm saying this? Because we must be sure that the patient has no triggers, to remove triggers when possible, to promote the improvement of mood and the reduction of anxiety. Otherwise, the effect of the prophylaxis would be less. I have used the song, the title of the song of the Beatles, Migraine Prevention, The Long and Winding Road. Why? Because it's really a long and winding road. The road which moved from methotrexate in late 50s and came to topiramate in 2000. We have had a lot of drugs which were originally indicated for other disorders, often discovered by serendipity, and unfortunately characterized by high discontinuation rate, and in some cases no longer marketed. What was the rationale? We have to treat the brain by acting inside the brain, reducing the excessive excitability, restoring the biochemistry. And the rules were use only one drug per time, slow titration, slow down titration, and a relatively short duration. These drugs, which are obviously effective, where we still use, have, however, adverse events which may decrease their adherence. Now we have other opportunities. You all know the monoclonal antibody to CGRPs. 4 are now available in some countries, 3 of them in Europe: eptinezumab, erenumab, fremanezumab, and galcanezumab. They share a lot of aspects, but they have also some differences. Erenumab is the only fully human and targets the receptor CGRP. Galcanezumab is the only one with the loading dose. Eptinezumab is given intravenously, and fremanezumab has a flexible dosing regimen. But these monoclonal antibodies changes our prior rules, because we now know, actually we also have known from botox, that it's possible to modify the brain, the migraine brain, by acting from the periphery. And we can use also these drugs as add-on therapy, and no titration is needed, and we can prolong the treatment for many months. How do they work? They work very well. Here you see the reduction in monthly migraine days for episodic migraine, EM, and in monthly headache days for chronic migraine, CM. And as you see, in episodic migraine, the mean reduction in migraine days ranges from 3 to 4, 5, and in chronic migraine from 4 to 8. But on the right-hand side, you also see that these drugs are extremely active also in patients with prior therapeutic failures. And if you look at the orange bar, which refers to the therapeutic gain over placebo, you see that by and large, the performance of these drugs are similar. We know that the patient is defined as responders if he shows a reduction of at least 50% in the days of migraine at the end of the treatment. With the monoclonal antibody, it has been studied mostly as post-hoc analysis, but sometimes also as secondary endpoints. The proportion of patients who are super responders, at least 75% of reduction, or in some cases 100%. TG means therapeutic gain over placebo. And here you see also in a patient with prior therapeutic failures, in those hard to treat, what the meaning of this slide. Even in patients very hard to treat with no hope, monoclonal antibodies may, not must, may work. What is really enthusiastic for us is to see that apparently these drugs has no class-related adverse event, and their tolerability is excellent. These were the results of the randomized control study, but what does it happen in real life? I show you the result of the IGRENU, which is the Italian migraine registry, and we demonstrated in prospective studies over 3 months in high-frequency episodic migraine and chronic migraine that actually the proportion of 50% responders is much higher than 30–42% of the RCT studies. It's 56 to 60 to 78, and this proportion is maintained also at 6 months and 12 months. We also have looked for efficacy predictors. This data has been published. Obviously, these are suggestions, are hypotheses that need to be confirmed also by your clinical work. But patients with allodynia, with triptan responsiveness, with unilateral pain, males more than females, and patients with dopaminergic symptoms and higher baseline migraine frequency respond better. On the other hand, body mass index, too much prior therapeutic failures and complex psychiatric comorbidities seems detrimental in the effects of these drugs. So we have a lot of good news on monoclonal antibodies to CGRPs. The first one, they are effective regardless migraine type, as this is a revolution, episodic or chronic or medication overuse. It's the same. They start working very soon. We did the first 4 hours in an ad hoc design eptinezumab trial. They improve not only the days with migraine, but also analgesic use, pain intensity, patient-reported outcomes. No cardiovascular issue. In some patients, don't lose your hope, because the response may occur later than 3 months. Their effect is sustained over time, low immunogenicity, no drug interaction. But We have also bad news. 40% of patients do not respond. Some patients have wearing off of the effect following each administration, especially in the first ones. In most cases, we see relapse after the continuation, and at least with this way of using it, they do not seem to be disease modifier. Some open question remain. Who are responders? Who are the non-responders? How long should the treatment last? When should concomitant prophylaxis be stopped, suddenly or later on? It's worth adding standard prevention in poor monoclonal antibody responders. This is a provocative slide. If we have a look to the proportion of responders to trigeminal targeted treatment, it seems we have a sort of ceiling effect, 60%. Why? I don't know. But I told you it was a provocation. 60% by and large is also the proportion of patients having unilateral pain. So to me, it sounds like those having the clinical symptoms of the trigeminal vascular activation are those who respond to trigeminal targeted treatments. This is my last slide. No, probably not still one. I'm trying to sum up my presentation. First of all, in acute preventive treatment, please do not forget that standard of care treatment are still very useful, both in acute treatment and in preventive treatment. But we now have specific and selective drugs, which increase cardiovascular safety, increase tolerability, and in prevention, increase treatment adherence. Nevertheless, almost 40% of patients do not properly respond to acute treatment and preventive treatment. Other mechanisms involved? It could be. But when we deal with prevention, please try to become far-sighted and look the patient from far. And probably he has also comorbidities or has not changed his lifestyle. These new opportunities prompt us to rethink the use of the term resistant or refractory to migraine. And I think the further study, future study, should address other efficacy endpoints: the total pain burden, frequency, intensity of pain, and duration of pain, and also interictal disability. Lastly, let me conclude with 3 slides referred to my country, Italy. The first one is Ferrari Puro Sangue, is the first hybrid sport utility vehicle. And to me, it represents new drugs. Costly, very costly, but an excellent efficacy, tolerability. This is a hybrid engine. The second slide is Tuscany, Valdorcia, is a wonderful landscape. And for me, this is our clinical practice because there are some hills and also a lot of curves. And the last, the pilots. This is Ferrari pilot. We are the pilot. What is our task? Please, we have not only to drive the car on the road, so to use the drugs in our clinical practice, but as F1 pilots do, we have also to contribute to the fine-tuning of the engine. So we have to give feedback, and we have to test and to open new scenarios for the treatment. Never forget that migraine treatment up to now was based on serendipity, and serendipity comes from our unique clinical activity. Thank you very much for your attention.
Thank you so much, Professor Barbanti, for an excellent lecture. I know it's a challenge to cover migraine treatment in a short time, but I think you did very well. I can see that there are already some questions in the Q&A. We'll have a Q&A sessions for both Professor Barbanti and Professor Anne MacGregor at the end. So please write your questions in the Q&A section, and then we'll go through all the questions at the end. Let me just shortly introduce myself. My name is Henrik Schütz. I'm a neurologist from the Danish Headache Center and co-chair of the Education Committee under the IHS. And I'm very happy to co-host this event together with my good colleague, Dr. Marcio Natan from Brazil. Now, it's my honor to introduce the next speaker, Professor Anne MacGregor, who is a specialist in headache and sexual and reproductive healthcare at Barts Health NHS Trust in London, as well as being affiliated with the University of London. Professor MacGregor has extensive clinical and research experience in many aspects of primary headaches, but her interest and focus is on the effects of sex hormones on headache. And on top of that, she's an excellent lecturer. So I look very much forward to a presentation on migraine and headache medications during pregnancy and breastfeeding.
Thank you very much. Let me just share my screen. Okay, so thank you very much for that very kind introduction. I think I started out life in headache as being a headache specialist with an interest in sexual and reproductive healthcare, and I seem to have become a specialist in sexual and reproductive healthcare with an interest in headache now. So interesting how times change. So what I'm talking with you today is very much about migraine treatment in pregnancy and lactation, following on from the setting of medications and treatments that are available to you from our previous speaker. So let me introduce you to Alice. So Alice, she's 28 years old. She has a history of 1 to 2 attacks of migraine per month without aura, and she treats those with the triptan. And she has just found out that she's pregnant and she is terrified of losing the baby. So what Alice wants to know is, will migraine harm my baby? What are you going to say back to her? So the good news is the evidence is very much towards the fact that there is no increased risk of miscarriage, stillbirths, or congenital defects with in respect to actually having migraine. But I will show you a little bit more about how it can affect other medical conditions a bit later on. Next question Alice has for you is, what effect will pregnancy have on my migraine? Well, most migraine gets better, and that's particularly the case for migraine without aura, in which case approximately 70% of attacks of migraine for aura will improve or even disappear during pregnancy. Not quite such a good picture for migraine with aura, where only 40% of attacks are likely to improve. And indeed, if migraine is going to occur for the first time during pregnancy, then often it will be migraine with aura. And also, if you have a history of migraine without aura, you may also experience aura for the first time. Now, the improvement is particularly in those women who have a hormonal pattern to their pre-pregnancy attacks. So women who have a history of menstrual migraine, so that's where migraine attacks are more likely to occur with menstruation than one would expect by chance. As you can see from the purple lines, the improvement is much greater than those women who have no such association with menstruation. And if it is going to improve, the likelihood is it will usually improve by 14 to 16 weeks of pregnancy, so towards the beginning of the second trimester. And it is important just to warn women that sometimes in early pregnancy, things can get a little bit worse before things get better. And that's particularly around the time where they get a lot of pregnancy-associated sickness. Migraine can accompany that, but in general, the improvement will be by the beginning of the second trimester. And that makes it important when considering what treatments you give, because certainly from the perspective of prophylaxis, if you start prophylaxis or considering starting prophylaxis in the first trimester, will you actually still need to be continuing it later on? So segueing on to treatment, Alice is then asking, how should she treat migraine while she's pregnant? Well, as always, think of lifestyle things first of all. Think of the simple things that you can do that are safe, but also effective. So we know that things like physical therapy, stress management, and biofeedback are effective in pregnant women and as in the non-pregnant state. So always encourage women to think about the non-drug management, not just the drug treatments. Now, drugs used in pregnancy, actually you will see from this slide that women use a lot more drugs than you might expect. And that's probably because drugs aren't as dangerous as many women believe. So in this cohort from Norway, nearly 73% were using drugs to treat attacks during pregnancy. So that provides us with data of seeing what women do and also how effective they actually can be. And notice in particular that triptans are included on this list of treatments. So what's safe that can be used? Well, first line in the green, paracetamol together with prokinetic antiemetic ideally, but also prochlorperazine can be used. Now the problem with that, if paracetamol didn't work in the non-pregnant state, it's not going to work in the pregnant state either. And yet it is the one that most women are told is the only drug that they can take during pregnancy. So second line, you can take non-steroidal anti-inflammatory drugs. There is a potential concern that they may or should only be used in the second trimester. There are some very limited data that it may, NSAIDs may increase the risk of spontaneous abortion in the first trimester, but one has to say that there is a degree of uncertainty about that. And to be sure, if a woman has taken non-steroidals in the first trimester, it's certainly, most certainly not a reason to consider termination of pregnancy. Similarly with sumatriptan, although it is third line, I will show you some of the data about safety. Perhaps maybe we are underusing it with respect to what the safety data are telling us. But always the question is couch it, if something happened to the baby, how would you feel about the treatment that you have taken, even though we can be reassuring you that it's safe, because there's a lot of guilt and other emotions that are involved with pregnancy loss. One thing to avoid is opiates, not so much because of safety issues, but because they are inappropriate for the management of migraine. They shut the gut down further, they can delay recovery and exacerbate nausea and vomiting, which in itself can be a problem, particularly in early pregnancy. Absolutely contraindicated are the ergots, so ergotamine and dihydroergotamine, even though you will have noticed from that previous slide from the Norway cohort that a few women had been using them during pregnancy. So let's turn to our attention to safety of triptans in pregnancy. So just bear in mind that the background risk of birth defects is about 4% in any case. So we need to be looking at all the data with respect to bearing that background figure in mind. And if we look at the sumatriptan pregnancy registry that was set up by Glaxo many years ago, and actually they stopped it after, I think it was about 20 years, because there was no new data coming through, nothing further of interest. But you'll see that an exposure in the first trimester to sumatriptan, the percentage of birth defects was 4.2%, and similarly with exposure in any trimester, 4.2%. So it's very similar to what we expect or what we see with respect to the background risk. For other triptans, we really don't have a huge amount of data. That's not to say they're harmful, but we just don't have the evidence. Now, emergency treatment for women who've got long duration attacks that are just not resolving, there are the options of intramuscular metoclopramide and intramuscular prochlorperazine, both of which can be effective at aborting a long duration migraine attack. You can also consider magnesium sulfate as an intravenous preparation with or without prochlorperazine. Now, magnesium sulfate is often given to treat eclampsia in pregnancy, so we have that history of it being safe for other uses in pregnancy. Now, what about if Alice needs migraine prophylaxis? What can she take for pregnancy then? Well, the ones that have sort of stood the test of time and safety are propranolol and amitriptyline or nortriptyline, as well as verapamil. So you'll notice that these are relatively low doses. I have had a few women who've used much higher doses during pregnancy without evidence of any harm. Where there has been harm, particularly because it always comes up with discussion with beta blockers, it is probably because those drugs have been used for women who already have severe hypertension, and there is evidence that hypertension can in itself have an adverse effect on pregnancy. So if there have been adverse effects reported, it's more likely to be due to the underlying condition for which those drugs were used as treatment. We want to really avoid drugs like candesartan, the CGRP antagonists, I'll mention a little bit more shortly, gabapentin, pizotifen for those countries in which it is still available, and topiramate. Absolutely contraindicated are the ACE inhibitors and valproic acid. And indeed with valproic acid, the FDA you have to ensure that a woman is using very effective methods of contraception before being prescribed valproic acid, and it is probably not sensible to even prescribe it to a woman during her reproductive years for migraine management. A few question marks, just because they are non-drug, as it were, does not mean to say that necessarily repeated doses of coenzyme Q10, magnesium, or riboflavin in continuously high doses are safe in pregnancy. Now, looking at Botox. Now, there are very few studies, and I know that it is an area of great debate with respect to management of women in pregnancy. There have been a couple of papers. This was a retrospective case report looking at, I think it was just over 200 or something cases, I can't quite remember, but they together with another 9-year study that was looking at 45 cases who were exposed to botulinum toxin during pregnancy. We really can say that there does seem to be no effect of the toxin on pregnancy outcomes, but that is very much couched in the fact that the data are limited, and certainly long-term data of what happens to the children who are born during a Botox-treated pregnancy, we just don't have those data. So you need to discuss what those data are, the limited evidence, and it's really a discussion between the clinician and the woman being treated. But if she chooses to stop, then obviously because the duration of effect of Botox, you need to consider discontinuing at least 3 months before conception. Now let's move on to CGRP antagonists, because they are the new kids on the block. And there are, again, very few data. So this was the latest publication looking at 94 safety reports from ireniumab, galcanezumab, and fremanezumab in pregnancy and lactation. It was the WHO pharmacovigilance database that was looked at in this respect. And again, there were no specific maternal toxicities, patterns of major birth defects, or increased reporting of spontaneous abortion in those women who were exposed to the CGRP antagonists. Again, we can only say that data are limited and long-term data are lacking. And the recommendation is very much to discontinue at least 5 months before conception, because that is a length of time it takes for CGRP antagonists to be completely removed from the system. However, for both Botox and CGRP antagonists, if a woman has been exposed to them during pregnancy, then one can reassure the woman that the data are favorable with respect to the outcome of the pregnancy, and there would be no good reason to consider that exposure to require termination of pregnancy. Neuromodulation. Well, there are no studies specifically in pregnant women with headache, but there is a low theoretical risk, and that low theoretical risk is backed up by no evidence of harm. And although the data for migraine and neuromodulation in pregnancy are very limited, there are a lot more data on women who've been exposed to neuromodulation treatment during pregnancy for other conditions. So no evidence of harm. So Alice leaves your office feeling pretty reassured, because she now feels there's actually lots of different treatment choices that she has, and that in itself makes her feel a lot more comfortable about progression of pregnancy. Sadly, she returns at 14 weeks of pregnancy, rather worried. Now, what's happened is that yesterday she developed bright zigzags in her vision, lasting 20 minutes, and that was followed by her usual migraine headache. So a situation that she's never had before, except that she's pretty sure it's migraine aura because her father has described very similar attacks. So you check her over, physical examination, neurological assessments are fine, blood pressure low as often expected in pregnancy, 90/60, and her weight gain is equivalent to what you would expect from her pregnancy dates. So is it migraine with aura? Well, what you need to do then, you need to really take a full migraine history of exactly what she's describing. So migraine aura can start for the first time in pregnancy, first ever attack of migraine, and in women who've previous attack of history of migraine without aura. So if you take that history and the symptoms are absolutely typical of that slow progression of symptoms, zigzagging, moving across the visual fields, the visual disturbance is present with the eyes shut, and it's often typically bright, then you can reassure her that there will be no usual harm or nothing to particularly be considered apart from monitoring for reasons I will mention very shortly. However, you do need to think in the back of your mind, has she got a thrombocytopenia? Might she have a cerebral venous sinus thrombosis or perhaps imminent eclampsia? Now, imminent eclampsia in a woman who has a history of migraine, then that can be associated with a 2- to 3-fold increased risk of preeclampsia. So this is something that we do need to monitor our migraine patients in during pregnancy. So it's raised if they have a pre-pregnancy history of migraine, and it's raised further if that migraine continues during the course of their pregnancy, and it's also a greater association with migraine with aura. So do monitor the blood pressure in your patients if you're not sure. So what if you're needing to investigate patients? Well, MRI is the imaging technique of choice. If she needs a CT scan, don't withhold it if it's necessary, but do avoid contrasting agents unless it specifically improves the diagnostic performance, and that is likely to lead to improved fetal or maternal outcome. What about after the pregnancy? Well, you do just need to watch for increased risk of cerebral infarction for 6 weeks postpartum, and that is significantly greater in women with migraine, and it's also significantly greater in women with pre-eclampsia of pregnancy. So further monitoring is important. Fortunately, Alice delivers a healthy baby with no complications and at term, but she's now asking about migraine and breastfeeding. Well, breastfeeding maintains the same benefits on migraine as pregnancy. So it's certainly to be encouraged, as it also delays the return of menstruation and menstrual migraine for those at risk. You treat as for during pregnancy, with the exception that aspirin is contraindicated. And with triptans, you have sumatriptan or elatriptan, and that little logo was there to say that you don't need to pump and dump, for those of you who understand what I'm talking about. So no interruption of breastfeeding. Prophylaxis, propranolol, metoprolol, and amitriptyline or nortriptyline have all been used without concern during pregnancy. And next time, well, you can reassure her that if she gets pregnant again, she perhaps won't get the same benefit that she got first time round, but she will still get a benefit overall. So to summarize, migraine without aura typically improves during pregnancy. Migraine with aura is less likely to improve. And most acute and prophylactic treatment of migraine is safe during pregnancy and breastfeeding, and you can certainly adjust it accordingly if it's needed. And atypical symptoms should be investigated just the same as for non-pregnant women. So thank you very much. And a little bit of further reading that you might look is just a systematic review of management of primary headaches during pregnancy, postpartum and breastfeeding, just published in Headache 2021. Thank you very much.
Thank you very much, Professor Anne MacGregor, Professor Barbanti. Very great lectures. And we have some questions already in the QA session. Whoever wants to ask questions, please go there and write, and we try to go through the most we can here. If I can start, Henrik, the first question is regarding vitamin D deficiency, and if there is any relationship with migraine. It comes from Selva Kumar, a physiotherapist in India. Thank you. And maybe regarding migraine treatment with vitamin D, is there any evidence, Professor Barbanti?
Yes, I missed to say that I focused only on the most important pharmacological migraine treatment. Yes, there is a paper published on the Annals, I guess, from Rami Bernstein, which demonstrated the effect of vitamin D. Vitamin D has a lot of effects on the brain, probably also on its excitability. But up to now, there is not a specific recommended treatment for migraine.
Thank you.
Great. So the next question we have is from Claire Sparks, and it's regarding GPANs and DTANs. And she's asking if they cause medication overuse headache. So I think that may also be addressed to Professor Barbanti.
It's a very good question and a very difficult answer, because we are not aware of medication overuse with these drugs. I think that the risk could be reduced because by counteracting the CGRP receptor, for example, with erenumab for months, erenumab is a monoclonal antibody, actually, you do not have a sort of new headache. But we have to test this. My personal view is that the risk that should be demonstrated and assessed is probably reduced or absent.
Great. I think as it was the first lecture, the first questions are also addressed to Professor Barbanti. Corina Maria Soco Macalintal from Philippines. She asks a very interesting question. Can we, Professor Barbanti, consider anti-CGRP drugs now as first-line preventive treatment or not yet?
If they cost €1 per vial or $1 per vial, definitely yes. But we cannot consider first line only due to the problem of prices. They are selective, specific, increase adherence, an extremely advantageous ratio between efficacy and tolerability. But unfortunately, they are not first line only due to the cost.
Great, thank you. So next question is regarding NSAIDs, and it's Sergey Markin who's asking which NSAIDs are the safest during pregnancy. So that probably goes to Professor MacGregor.
Which NSAIDs are the safest? It's a bit of a difficult one because it depends on what is actually being used and what studies have actually been done. I mean, I have to say that when you look at the data, really, while there is concern about ibuprofen, it's the one that people buy over the counter. So other concerns really based on the fact that it's used more. And so you pick up more signals as a consequence of it being used more. I think, you know, certainly in pregnancy, the obstetricians use things like diclofenac quite a lot. So if you bear in mind that they are using those types of NSAIDs during pregnancy anyway, then perhaps those are the better ones to be using for headache as well. And we know that they can be, diclofenac is effective for headache too. But I think it's something, you know, again, don't be too concerned about if you find patients have been using it, because we are always far more cautious about use of medication in pregnancy than perhaps we necessarily need be for the you know, obvious reasons of the distress that will happen if there is a pregnancy loss.
Great, thank you. Dr. Puburu from Sri Lanka asks, thanks both speakers for the superb presentations, and ask in your setting regarding what Professor Piero answered, the cost matters. So can the relative beneficial effects of newer drugs over the traditional medication justify the huge costs of these new drugs, or in which settings could it be justified?
I mean, if we talk on monoclonal antibodies, on biological drugs are costly because the way of producing them is very complex. I would say that the excellent ratio between the efficacy and tolerability really is so amazing that probably the cost is worth buying, but it's worth reimbursing from the health system. Really, the monoclonal antibody 2-CRP to me are not the new drugs for migraine prevention, as the first drug for migraine prevention. And even the fact that the tolerability is really excellent probably means that we are on a crucial target. I'm not sure that is the only target, but we are on a precise and good target. An example is levodopa. If you give levodopa to Parkinsonian patients, have no side effects. If you give to patients with vascular Parkinsonism, they have nausea. So probably this demonstrates that we are on the right target.
Thank you so much. So the next question is from Dren Bošnjako from Kosovo, and he's asking, what about duloxetine as prophylaxis for chronic migraine concomitant with depression? And he's asking if compliance may be compliance and effect may be better than amitriptyline.
Me?
Anne MacGregor is also an expert.
Well,
so it's totally up to you, or the cat. The cat can also answer, maybe.
Sorry, I was too distracted then.
Duloxetine has no indication for migraine, as is not included among the drug active, because migraine does not respond to antidepressant. Response to amitriptyline, to nortriptyline, may respond to venlafaxine, and even though duloxetine shares the same mechanism of venlafaxine, which has been considered helpful as a second or third line in migraine, there is no scientific evidence that duloxetine works. Duloxetine works in neuropathic pain, probably in fibromyalgia, probably in low back pain, probably in neuropathic pain.
Thank you. Claire Sparks from UK again. She asks, as many patients report migraines upon waking, what is the best way to treat these? It is unlikely to catch them within the first hour.
To me, this is a big challenge in our everyday clinical practice. Subcutaneous sumatriptan could be one solution. The second one, the use of indomethacin. Have you seen indomethacin never cited? Because strange to say, indomethacin, which is so helpful, has no randomized control studies. In Italy, we have an association of prochlorperazine, indomethacin, and caffeine, which works very well in this kind of attacks. I would say definitely indomethacin 100 milligrams.
Thank you. And the next is from Professor Toga, I believe, from Iran. Good to see that you are part of this webinar. She's saying, thank you for excellent presentation and nice session. Is there any consideration regarding doing MRI during the first trimester of pregnancy?
I think the issue really is no, is the answer. You know, if it needs to be done, do it. Really, if it needs to be done, do it. So there is no issue.
Great. Then we go to Manuel Vides Rosales, who asks, what is the recommendation on peripheral nerve blocks during pregnancy and breastfeeding?
Peripheral nerve blocks, again, we have not a huge amount of data, but no evidence of harm. You know, I certainly in my hands, I've never found them to be particularly helpful, rather than just giving sometimes a very temporary respite while you sort something else out. So can be used, but no concerns.
Thank you.
All right, so I believe the next question is regarding why propranolol. This is from Gianni Alais. Why propranolol and not metoprolol during pregnancy for migraine prophylaxis? Probably there is lesser risk of IUGR. I'm not familiar with that.
Yeah, it's really just the evidence that is available, and propranolol is used more frequently. So atenolol, for example, there is an increased use of intrauterine growth retardation. But again, we don't know whether this is because that the underlying medical condition that women have taken these drugs for during pregnancy. So such hypertension was one that I was mentioning before. So, you know, some of these data are extrapolated not from migraine treatment, or indeed they're not extrapolated from migraine treatment. They're extrapolated from the use of management of other conditions in migraine. So it's really just trying to find the safest ones, and propranolol is the one that comes up.
Great. Another one for Professor MacGregor. Do you investigate coagulopathies and/or cardiovascular disorders during pregnancy in patients suffering from migraine with or without aura? From Cinzia Cavestro.
You need to investigate them in exactly the same way that you would a non-pregnant patient.
Great, and we now have a question regarding treatment of children, so you can both answer. This from Guy Yeganin from Armenia. Which therapies are the safest for children, especially for younger ones?
So in terms of acute treatment and or preventive treatment, yes, both. Ibuprofen is the drug which has more scientific evidence of being helpful in acute migraine treatment. In children, the first rule is to improve their lifestyle when we want to prevent their migraine, to promote their sleep, regular breakfast. In Italy, young boys do not have a breakfast. So ensure that he's correctly having breakfast and lunches. And usually we start, it's a good option to start with a so-called metabolic enhancer, as Anne MacGregor pointed out, riboflavin 400 milligrams, or coenzyme Q10 300 milligrams, or magnesium. And so nutraceutical approach may work. Otherwise, you can use all the other class of drugs. Topiramate, I do not use because they have to go to school, and so the cognitive effect may be not so accepted. Amitriptyline, flunarizine, mostly in Italy, and the beta blockers. Now we have in our clinical center a trial with Tremenesma, but this is the future. So the pharmaceutical companies are also testing the efficacy and the safety of current monoclonal antibodies to CGRP also in pediatric population, but it's not yet indicated nor approved.
Yes, that's very straightforward. I would add to the lifestyle aspects, first of all, because there is evidence that children learn very much from the way that their parents have treated their migraine attacks. And if they have a parent who tends to overuse medication, that will be something that they tend to pick up as well. So looking at all the lifestyle strategies are very good. I think in the UK, it's much the same as Italy, I'm afraid, but worse, you often see the kids walking to school, eating a packet of crisps. That's their breakfast. So looking at the timing of attacks, because so often you see that children will get them towards the end of the school day. And when you go back and look at what's happened during the school day, they're just not eating enough for what they're doing. Growth spurts is another particular time. Exercise can often be a trigger, lack of sleep hygiene, all of these good habits that you want to instill into them at an early age and treat appropriately rather than just reaching straight for the medicine bottle. Otherwise, we'll have a whole host of chronic little migraineurs going along the line.
True. Next question coming from Farai Doon, a colleague from the Electronic Media Committee. He's from Australia now, and he thanks for the amazing presentation. Asks, do you have any suggestions for study designs to evaluate treatment of migraine during pregnancy?
Well, that is always a really difficult one, because who is going to be brave enough to specifically give drugs during pregnancy? And there is always that fear of what happened with thalidomide, for example, of these drugs. So I think we are faced with just safety monitoring of women taking drugs during pregnancy. And we want all the pharmaceutical companies to have a pregnancy registry. We want every person to who comes across a patient who is taking a medication while they are pregnant to actually make a note of what that was and report the outcomes of it. And that way we will be able to pick up a much broader picture of what happens. Maybe this is something IHS could set up as a database.
Great idea.
Thank you very much. The next question is from my good colleague Sumaye Baki Sadeh from Iran. Is there any concern about the hormonal therapy used to induce folliculation in vitro fertilization in those with migraine with aura, for example, about the increased risk of vascular risk because of high dose estrogen vascular event?
Yeah, it's an interesting one, because they're often using gonadotrophin releasing hormone analogs as well, and that can sort of excite the whole hormone activity before it shuts down the ovaries, and then they do the replacement. So you start off by often getting a little flurry of more migraine in those first few weeks of treatment with that. And then with the high doses, I mean, we work with the fertility departments and very strongly recommend that they use transdermals rather than oral estrogens in those situations. They're also using very high doses of progesterone, and those are sort of excitatory, so they do seem to have a sort of slightly calming effect from the excitatory effects of the higher doses of estrogen. So trying to keep the hormone levels stable is fine, and transdermals, we know, do not adversely affect clotting parameters in the same way that the synthetic oral estrogens do.
Okay, thank you. Konstantin Kondratyuk asks, thank you all for the interesting talks, and asks, how long should the patient take preventive therapy, topiramate, for instance? What is the max possible dose for topiramate? And what is the target of preventive treatment? Decrease of the attacks or disappearing at all? He asks from Ukraine.
It's a very good question. The therapeutic dose ranges from 50 milligrams to 200 milligrams. Most patients respond to 75 to 100 milligrams. It depends also on the weight. How long should it last? We usually use, at least in the episodic form, prevention for 4 to 6 months. To me, better to 6 months. But if the patient has a history of chronic migraine, has had or has medication overdose, it can be prolonged for longer time, also for 1 year or more. The second part of the question, what's the goal of the effective preventive treatment? The endpoint we have used up to now is the reduction in migraine or headache days. But sometimes the patient is happy, even though the reduction of the migraine days, headache days is not of at least 50%, because he has milder attacks with lower accompanying symptoms. But up to now, all the trials were designed by counting the number of days of migraine. So with a scientific answer to your question, the patient should have a reduction by at least 30% if chronic, 50% if episodic migraine in the monthly migraine days.
Thank you very much. The next question comes from Hafiz Altai. Thank you for this presentation. People with migraine tend to avoid physical activity. Do you think some activity like yoga and Pilates may be effective in migraine treatment?
I think so, and it has also been demonstrated for a couple of reasons. First of all, can you hear me?
Yes.
Because
yes.
They are probably out. For a couple of reasons. First of all, because relax helps. The second point is that the activation of the parasympathetic system, which counteracts an overactive sympathetic system, is helpful in migraine. This one.
Okay. Well, next one comes from Corina Macalintao. She asks, what's the longest?
Hear you. Just a moment.
Okay. If you want to proceed for the next question, Henrik, for Professor MacGregor.
Yes, so this is from Elinia Maya Melhado. Good afternoon and congratulations, Professor Anne. I admire you. I think many others do. Do you like magnesium for menstrual migraine?
The evidence suggests it's actually more effective for premenstrual symptoms rather than menstrual migraine. So, so I tend to use it on people who are struggling with PMS as well as menstrual migraine. You've got to watch the dose as well because of the dietary gut effects that it can have. Yeah. But it's actually very good for the late luteal phase PMS constipation as well.
So would you use it every day or just during the
people find it much simpler just to take it as a daily dose.
Okay.
And then if they haven't found any benefit from it from after 3 months, then there's really no point continuing, because people keep tending to add on and add on and add on more and more things, rather than ever thinking about actually it might be a good idea sometimes to take something away.
Can you hear me now?
Yes,
Yes.
we can hear you.
Okay, without headphones.
Okay. The question for you is from Karina Makalintal. She's asking, what's the longest length of time that you have used an anti-CGRP mAb for?
Yes, we are now treating patients for more than 25 months. It's not the rule because we now have some restriction. In Italy, we have to stop following 12 months. And my personal view is that as we have to desensitize the brain, inside the brain, by acting outside in the nerve, the longer is the better. The problem, the issue is just money because it's too expensive. But we are now controlling our data on safety in an extra long-term treatment in real life, and we did not note any increase in adverse events. So the drug maintains the tolerability and the safety and also the efficacy in those who are being treated. But 25 months only in patients who respond.
Yeah, it's then very difficult getting them off them because it's so effective.
So the next question is from Sergey Markin. We have touched a little bit about it, but this is more specific regarding experience using Syphily for relieving headaches during pregnancy.
Yeah, that's definitely a good option to try.
Yeah, good. Thank you.
Now from Putri Auliua. Thank you, both speakers. She's from Indonesia, or he's from Indonesia. I have a question for Professor Anne. In first trimester, if paracetamol is inadequate for pain relief, is there any modalities other than triptans? Because not all hospitals in the country have that drug.
Yes, I mean, I think although I said avoid opiates, sometimes you are just really limited by what is available, and then it's just trying to work out what is in the best interest for the patient. So some women do find that paracetamol, if it's combined with codeine, will be effective for them. And I think it's very much then just trying and seeing what works for the patient, bearing in mind that, you don't want to do a blanket prescription of opiates to all pregnant patients because opiates are not the best thing to give for migraine, but they do work for some people. And I think in those situations, you look at what the potential safety of a medication is and you try it, and hopefully that will be effective. And don't be too afraid of non-steroidals.
Mm-hmm. Thank you very much. The next question is from Dr. Santanu Nath, who is a psychiatrist from India. How can one differentiate a prodrome from an aura in migraine?
Who's going to answer that?
Well,
yeah, it's almost a very simple way of doing it is if the patient hums and haws about the symptoms that they have to start off with, it's very likely to be a prodrome and not an aura, because they don't forget what an aura is like. If you ask them, what warning do you get when you have a migraine, and they start describing zigzaggy lines moving across their field of vision, and they're getting visual disturbances that last for up to an hour that typically resolve before the onset of the headache, but not always. And those bright visual disturbances that are spreading across the field of vision, typically for about 20 minutes, they still see them with their eyes shut. And that is very different from the slow sort of continuous spots in front of the eyes, or feeling extremely hungry, or craving carbohydrates, or being much more sensitive to light and sound, that we know are symptoms that the attack is present already, typically anything up to several hours to up to 1 to 2 days before the onset of the headache. those are much more or less specific symptoms. So, people who have aura know that they've got aura. They describe it very beautifully, and you just say, "What do you see?" Just draw in the air what you see when you have your warning, and that is very helpful at picking it up.
Great. Elena Lebedeva asks if there are any differences in prophylactic treatment in migraine in men and in women, and if Professor MacGregor knows the prevalence of chronic migraine in pregnancy.
Should we work backwards? Chronic migraine in pregnancy is about the same rate as in the population, so it's not that common. I mean, we see it a lot, obviously, in secondary care centres, but population, it's not that common.
And regarding the question, if there are differences in prophylactics in men and women, so it's the same. Yeah, good. So next question, thank you. So next question, that's a comment regarding pregabalin and gabapentin in migraine preventives. I have some patients who experience good response with them. So maybe Professor Barbanti.
Yes, we know that anticonvulsant may work in migraine prophylaxis, topiramate, valproate, which is not as easy to handle, and pregabalin as well. The dose may be high, up to 2,400 milligrams, and the only problem is the side effects, which may be pregabalin, gabapentin, for gabapentin, the side effects may be pronounced as sedation and somnolence, sometimes weight gain, but mostly sedation.
Okay, Muhammad Mansare, a neurologist from Guinea, asks, in which case the use of amitriptyline is appropriate and at what age especially?
Amitriptyline is effective. Amitriptyline is effective in both migraine, episodic migraine, chronic migraine, migraine with a medication overuse, and also in tension type headache. And it has also a secondary favorable side effect, which is the induction of sleep and the anxiolytic effects. And we have also always to bear in mind that migraine is the result from biology and biography. So stress is a very common, the most common migraine trigger. And amitriptyline, which is effective and which is also cheap as a drug, has also the advantage of acting on the most common trigger for migraine.
Okay.
And it works at very low doses. We know that it can be pushed up to 75 or 100 milligrams, but in most cases 10 to 25 milligrams at bedtime are enough.
So the next question is from Cynthia Cavestro. What about steroids during pregnancy in those with pharmacoresistant migraine? Maybe we could also ask, what about a cluster headache patient who is in a cluster period and is pregnant?
Yes, you can use steroids and you can use verapamil.
Yeah. Great. And Garik Yeganyan asks from Armenia, the sumatriptan intranasal spray works for migraine?
Yes, it works. It works very well. It's not so easy to use because it's not so intuitive. First of all, in which nostril? The side of the pain or the other side? At the side of the pain, you may have also sometimes another stiffness. So you are not perfectly sure of a proper absorption, but it works. And as I have showed, the subcutaneous, the intranasal formulation may work much better than the oral because the oral has a very low bioavailability, only 14%. The new formulation of aspirin has up to 100%. So bioavailability is dramatically increased by the intranasal, but the patient has to learn how to precisely inhale the drug.
Thank you. I think we have, well, if it's okay, there's one question I'd like to ask Professor MacGregor. So you showed that migraine with aura tend to improve during pregnancy. Why do we see this difference between migraine with aura and without aura? Is it because hormones drive migraine without aura more? I know it's a difficult question.
Yeah.
If you can
So migraine, in general, in very simplistic terms, migraine without aura tends to follow withdrawal of estrogen, and the evidence shows that high levels of estrogen tends to drive aura. So so you can see menstrual migraine, withdrawal of estrogen. As soon as you get into situations of contraceptive synthetic estrogens or pregnancy where you're beginning to get higher estrogen states, then that has a potential to trigger migraine aura. Ovulation's another time that we're more likely to see migraine aura.
Thank
you. So due to the time that we reach now, I'll ask a last question for Professor Barbanti from Anatha Velipuram, who asks from United States and asks, any experience in combination therapy of Botox and CGRP monoclonal antibodies?
I do not have a personal experience. It has also rationale because Botox and monoclonal antibodies act on different fibers of the germinal nerve. There are some studies, underway, and it can be, it can have a sense. It makes sense from a scientific point of view. The problem is only cost. Two very expensive drugs coupled together.
Yes.
Yeah.
Thank you so much. And I think we have to stop now. So I'd like to say thank you so much to Professor Barbanti and Professor MacGregor for giving excellent lectures and also taking all these questions that were excellent. I'd like to thank my co-host, Marcio Nathan, for again co-hosting. It's always excellent to do this together with you. Thank you so much to all those joining the webinar. Thank you for all the excellent questions. This webinar will be recorded and released on the IHS website. And I recommend that you become an IHS member to learn more about headache. So thank you so much, everybody, for participating, and have a great day. Bye-bye.
Thank you. Bye-bye.
Thank you.